it's a weird world that we live in because on one hand, there's a lot of skepticism for docs that are in the traditional world because those are the docs that are slinging opioids, those are the docs that are doing unnecessary surgeries. But then on the world that is still fairly experimental, for some reason patients trust those docs and are like, all right, I'm going to give you $10,000 to put things God knows where. So it's this weird dichotomy, it's this weird unbalance that's occurred in the musculoskeletal world right now.
I'm Heidi again, and we're here today with Dr. Patel at HealthLink Medical Center. And I'd like to introduce Dr. Patel and ask him to just tell us a little bit about your background and kind of your education, what you do here at HealthLink.
Sure. So my name is Shounuck Patel. My background is in physical medicine and rehabilitation. Actually, I'm a DO, a doctor of osteopathic medicine, and I did my physical medicine rehabilitation training over on the East Coast at Kessler Institute of Rehabilitation. And after that, I did a fellowship in sports medicine and interventional pain management. Since then, I've actually been focusing my practice on regenerative medicine and what's called interventional orthopedics. So using a patient's own biologics in order to treat various different orthopedic injuries, pain conditions, and trying to basically keep people away from surgery unless it's absolutely necessary.
Sure.
I've been interested in that for years. I first had my first exposure to regenerative medicine back when I was in medical school, and I was really attracted to the idea of the body being able to heal itself. So I kind of searched it out along the way, and it's been an amazing journey to see patients get such great improvement without things like cortisone injections and opioids and surgery. So it's been a really great trip, and I love working with great physical therapists like yourself.
Thank you.
That are like-minded, because unfortunately there's not a lot of great physical therapists that are out there. There's a lot that are very cookie cutter. But
I nod my head like, yeah, I know.
But ultimately, you're doing all the work. And what I do with the treatments that we have are really just helping along the process of what you're doing. So it's a great collaboration.
Absolutely. And, working with you has been fantastic, and I know I've said this before, but the fact that all of the education that you provide to patients is one of the reasons I like working with you the most, because so many people come into me and they don't know what these interventions are, number one. And number two, they see providers who are providing them with a variation of this, but being given very little education of what they're receiving, what to do about it. So they have very little expectation of what they should experience, and people think that this is like an overnight deal. Like, I have this, and like cortisone or my opioids, I should feel better in the morning, which, as we both know, is not exactly the case. And there's a lot of confusion, so it's really good to be able to bring more information for the general public, and especially the patient populations that I deal with, so that there are, this is kind of more light is shed on this, because as I greatly believe in this and would prefer to see patients doing this type of intervention versus a surgery or medications or other things that really don't necessarily help their overall health,
Sure.
or have a lot more potential consequences, scar tissue buildup, failed surgeries, addiction problems, whatever.
Yeah. With traditional medicine, traditional orthopedic care, right?
Yes.
It's really algorithmic. It's really looking at what's the pain generator and how can we treat that pain generator, but it's not really looking at what caused the pain in the first place.
Right.
And that's where physical therapy, physiatry, regenerative medicine really has its forte, because we're trying to look at things from all angles. We're trying to get the body to do the things that the body should be doing.
Right. Better function.
Better function. And that's really the purpose in the end. Yeah. But it's interesting, the world of regenerative medicine, and most people think of regenerative medicine and think of the word stem cell.
Yes.
And that's been gaining popularity, and it's become sexy over the past few years.
Right.
A lot of media attention and
Sports people.
so a lot of good attention, but then also a lot of bad attention, because quite frankly, there's a lot of clinics that are just making these vague and patients. Like, hey, we're going to inject these stem cells into your IV stream and treat your knee arthritis and your Alzheimer's and your multiple sclerosis, and we can inject your kid and treat their autism, and it's this whole spectrum of claims that are being made that are really, really unsubstantiated. So it really is the stem cell Wild West right now. And that's why I like educating people, because quite frankly, there are benefits that could be had from these, but these aren't a panacea. This isn't something that can cure everything. Right. We got to be realistic about what things can and cannot do. And to a certain extent, there's a lot of stuff that we just don't know at this point.
Medicine's too new.
Absolutely.
I think there's a lot of kind of a veil of mystery too about where do stem cells come from. There's all of the kind of talk about like the black market of stem cells, and like where are these coming from? And I think that there's a lot of concern and confusion regarding that too. And kind of where do you source these? How do you get them? So we can kind of talk about that maybe in our case study here.
Sure, absolutely.
So we've seen a number of patients together, and which has been fantastic. And me being one of your patients, so like I won't show my wing situation here, but one of our most kind of interesting cases has been Tammy's case, and so let's kind of talk about her a little bit, and I can kind of start us off talking about kind of her prehab before your procedures, and then we can kind of go back and forth. So Tammy is a mother of two. Her oldest is around 24, and she's had low back pain, pelvic pain issues very literally since her first child was born. And she's had a myriad of treatments, and she and I have gone back and forth for a number of conditions over the years. But a couple of years ago, maybe like 2 now, she had that spontaneous rupture of her plantar fascia. And she came to me saying, I've been in these like high-heeled work shoes, and like my foot's really hurting, and I don't know what to do about it. And when she came in, we started working and doing tissue work through the plantar fascia, and discovered that there was a space large enough I could basically fit my thumb inside of it. In which case I sent her to an orthopedic foot and ankle surgeon to get further evaluation. And fortunately, that surgeon, after doing an MRI, I was really happy that he just flat out said, like, surgery is not the best option for you. And I had told her kind of the same thing. I was like, listen, like surgery should be our last resort, because these just don't heal well. And in this case, after that surgeon agreed, which I will forever be grateful for, I referred her to you. And so, like, maybe we can talk a little bit about your evaluation of her and the first round of procedures that happened.
Sure. So when I first saw Tammy, obviously her main concern was her foot. She told me she had this back stuff that was going on and on and off for a while. That wasn't her main concern. She was doing fairly well with that for all intents and purposes. But she had this bottom of her foot pain in that plantar fascia area, right? And we see this all the time. This happens for various different reasons. High heels being one of them. That being said, I thought it was kind of weird that she had this one-sided foot pain. She had not changed her footwear dramatically. She was doing the usual amount of walking and standing that she was normally doing. So I was like, what's causing this? What's going on? And that's something that I think that when you have foot pain, you go to the foot specialist. That a lot of times we end up being very
tunnel
focused.
vision.
Exactly. And just kind of looking at that. But when we're talking about function, we have to take the whole body into perspective, right? So I examined her, and I realized when examining her that she had a little subtle weakness in her foot and actually in her hip, coming from her low back. So the nerves in the low back are in charge of the muscles of the legs, as we know, right? So those nerves, I tell patients all the time, the nerves are like the electrical wiring that go to the muscles, which are our appliances. So if those nerves are not firing properly, the muscles aren't going to work properly. And in that sense, the muscles are in charge of how we move our legs and move our feet, right? So she had this gradual nerve irritation that had been developing over however long.
20 plus years.
Right? So, ultimately something happened. There was the straw that broke the camel's back, essentially, and she was starting to put abnormal pressure into her foot. So the plantar fascia, it really makes up the bottom of the foot, and it is a part of the arch. It is essentially a strong tissue that stabilizes the bottom of the foot. But that tissue actually comes from the heel, which comes from the calf muscle.
And we've got that fascial chain just all the way up.
Absolutely. And then if the lower lumbar nerves, the L5-S1 nerves are involved, S1 nerve is involved with the calf.
Yeah.
So that abnormal pulling of that calf muscle ultimately pulled on the Achilles tendon, ultimately was pulling on the plantar fascia abnormally.
Yeah.
And over time, that fascia, the fibers of the fascia were probably getting gradually disorganized as those fibers were being pulled abnormally. So that, wearing heels one day and all of a sudden some of those fibers broke off and she had a more significant tear. So in evaluating that, I was like, shoot, we need to get the nerves functioning better in the low back, in addition to obviously treating the plantar fascia of her foot.
Well, starting from the spine and kind of working your way down.
Absolutely.
Yeah.
So the first treatment that we did was actually treating the foot and the plantar fascia, but also addressing the low back.
So you basically essentially did 2 injection sites.
Correct.
Okay.
So I won't get into the nitty gritty of the details about what exactly I was injecting in the low back, mostly because it was like over 2 years ago, so I don't remember.
Yeah.
But what we used were the growth factors from her blood, and I can go through what that means.
Yeah, we'll circle back.
Yeah, but essentially, we make these pro-inflammatory and anti-inflammatory mixtures from the blood. One that's very commonly heard of these days in the media and everything is called PRP, or platelet-rich plasma. So we make variations of that, and I inject it around the area of her low back to provide some increased stability to the low back, to take pressure off of the nerves. I also inject it along the nerves to get those nerves functioning better. And then I inject it into the plantar fascia directly, using image guidance, x-ray guidance for the low back, and ultrasound guidance for the foot itself. And she did mediocre. So
there was some closure. I mean, that gap, we saw in the MRI, like the gap started to close.
Yeah.
It wasn't, but it didn't resolve the problem.
Well, it was interesting because her back symptoms and some of the weakness in her leg had actually improved.
Yes.
When I followed up with her a couple months later. Her foot pain kind of improved, but not really.
No, she was still struggling and going through a lot of different shoes that she was, having a hard time kind of flip-flopping between shoes and arch supports and all this stuff, trying to get comfortable.
Absolutely.
And I think that that's important too, that you mentioned, like, your follow-up was a couple months later. Like, it wasn't like 3 days later. It was like a couple months, because we're talking about regeneration. Like, we're trying to get the body to regenerate, and the healing process takes time. It's not an overnight sort of deal.
Correct. And in this situation is regeneration. But there are a lot of situations where we're not actually doing regenerative medicine. We could talk about that. But in this situation, I wanted to try to heal that plantar fascia as much as possible. So we were like, shoot, we're not getting the results we want. Let's do a repeat MRI. Actually, to my surprise, the tear inside the fascia had actually healed predominantly. But the fascia was still thickened and it still had disorganized fibers.
Right.
She also had some other things going on with the ankle joint that may have been contributing to some instability, some irritation to the tendons around her ankle.
And she had that kind of old ankle injury, which probably played in.
Right, exactly. So it was all some mechanical stuff that was just preventing her from healing appropriately. So then we were like, you know what do we do at this juncture? The healing had been progressing fairly well, despite her symptoms not improving as much as we'd like. So the discussion that I had with her was like, maybe we should just repeat the PRP to try to get things to heal. But she's like, look, I've been dealing with this for so long.
Yeah.
Let's hit it with all it's got, all we've got. So basically, the other options in terms of treatment, there are other things that may be beneficial for this type of situation. There's actually some research that suggests that amniotic allograft.
Okay.
So this is tissue from pregnancy that is donated. It's cleaned. It is not a stem cell treatment, but it is containing growth factors.
Sure.
There is some evidence that suggests that may be beneficial for specifically plantar fascia.
Okay.
And then our biggest gun that we are using is the stem cells from a patient's own bone marrow.
Sure. So that isn't coming from the blood, like we're talking about the PRP. This is coming from like the hip or the pelvis.
Correct.
Yeah.
Correct. And that is essentially the biggest gun that we have. From the bone marrow, we're able to get layers of stem cells, true stem cells, and we are able to also get the actually make an extra rich PRP from that
Okay.
bone marrow as well.
Will you back up for just one second? Like
Yeah.
when we're talking about stem cells, can you explain like exactly like what a stem cell is? Because
Absolutely.
there's a lot of confusion. Like what is that and what does it do? So like why would you like we're saying it's a big gun, but why would we want a stem cell and what would that do over the platelet rich plasma?
Okay. Well, why don't I talk about what PRP is first?
Sure.
Platelet-rich plasma.
Yeah.
Because that is when we talk about regenerative medicine and the different biologics that we use, PRP is one of our tools. The original regenerative medicine technique was actually using sugar water injections.
Right, the prolotherapy.
Prolotherapy.
Yeah.
And the idea behind that was the sugar water actually causes some inflammation or irritation, tricks the body into thinking there's a new injury when there was a chronic issue going on. So like an ankle sprain that's been going on for a long time, that kind of thing.
Unstable ligaments, things like that.
Exactly. And then the body would then send platelets to the area, then would send growth factors to the area and start the healing.
Right.
So then PRP was like, hey, the way that it was kind of thought of originally was, hey, if the sugar water is causing this amount of irritation, then if we're injecting some blood platelets there, it'll cause that amount of irritation. Plus, it'll already have the growth factors.
Sure.
There. So it's kind of a prolotherapy plus. But since then, we've actually realized that the PRP is much, much more than just prolotherapy plus. PRP, platelet-rich plasma.
Yeah.
When you cut yourself, the platelets are the thing that stops the bleeding.
Sure, and knits it back together.
Yep, forms a clot. And then those platelets release growth factors over time.
Sure.
Some of those growth factors actually we've discovered actually cause inflammation.
Yes.
Some of those growth factors actually are anti-inflammatory.
Okay.
And some of those growth factors may actually bring other cells to the area.
Sure, like there's kind of that proliferation of things coming to the space.
Absolutely. So if you think about if you injure yourself with a cut or you twist your ankle or whatever, after the platelets stabilize that injury, they need to bring certain cells to the area like macrophages to actually get rid of the damaged tissue.
Right.
And that process is called inflammation.
And that's why we get our swelling and heat and redness and all that stuff.
That's exactly right. And that's why how we've actually changed the way we treat ankle sprains now, right? We used to
ice, elevate, rest.
Completely immobilize, put yourself in a boot or something, and that has changed drastically now because we want that inflammation to occur.
We don't want that to be slowed because that's our body's own natural process, right?
Absolutely, absolutely. So that's what the platelets do is they call cells to the area, they cause inflammation, and then they take that inflammation away. So we're able to take your blood, highly concentrate those platelets, and then inject those into various different areas.
Sure.
So that's what we used for Tammy.
First round. Yeah.
Now stem cells are a little bit of a different animal. So when most people think of stem cells, they're thinking of embryonic stem cells.
Sure. I was going to say Kobe Bryant, but embryonic is probably a better
Yeah, well, it was interesting. Kobe Bryant, the original treatment that he had was not a stem cell treatment. It was a totally different animal out in Germany. But you're right, Kobe Bryant and other athletes have really brought the idea of stem cells to the forefront.
Yes.
And then it's kind of exploded. And and now people are saying that stem cells would cure everything under the sun.
Right.
But what are stem cells?
Yes.
Back in the Bush era administration, they were trying to put the kibosh on using embryonic stem cells because the risk that it could have towards an unborn fetus, right? But this is not embryonic stem cells. Your embryonic, or what are called pluripotent stem cells, are those that can literally change into anything. And then they go down different lines of less differentiated or more differentiated stem cells that could then turn into specific structures. So you have your stem cells that turn into nerves, your stem cells that turn into heart muscle, your stem cells that turn into orthopedic type issues like bone, cartilage, tendon, etc. So the ones that change into your tendon, cartilage, muscle, etc. are called mesenchymal stem cells, or MSCs. And that it can be found in rich supply in areas like your pelvis and your bone, or really any bone in your body.
That has bone marrow.
That has bone marrow, correct. It can also be found in the fat, in actually a very, very high amount, and we'll talk about that too.
Yeah.
But it can also be found in the blood supply, on blood vessels, etc., just in lesser quantities.
Sure. And for this procedure, you want something that has a really high concentration.
Correct.
So you're going to go to a source where you can really pull that.
Absolutely. And So that's why we use the bone marrow. The bone marrow source of MSCs is the source that has been the most researched, by far has the most publications and research in the orthopedic world. And it is the only source of MSCs that is technically legal by the FDA.
Okay.
So, you know, I have a love-hate relationship with the FDA. I think that, you know, it's sometimes they're very, very stringent when they don't need to be. But sometimes, quite frankly, they have these rules in place ultimately for patient safety.
Sure.
And the reason the FDA says that bone marrow is legal and that other sources are illegal is because bone marrow falls into specific categories. Less than minimal manipulation, so it's not changed in terms of its structure.
Yeah.
It's autologous use. It's used for orthopedic conditions, which, you know, bone marrow has a very similar kind of use in general in the body. And versus things like your fat, the way to actually get stem cells from fat, you have to chemically digest it.
Interesting.
Which actually changes the fat and creates a solution called SVF, which is a solution that contains the stem cells.
Okay.
And that, per the FDA, they consider that more than minimal manipulation, and therefore creating a drug.
Sure.
Now, you can argue, is that actually creating a drug or not?
Yeah.
But the reason the FDA has taken this stance is because A, there's not enough research on it.
Okay.
Although there is some growing research in it. But B, more importantly, clinics across the country have started creating that SVF and injecting it IV and saying that they're curing everything.
Sure.
And it's become this whole crazy world that has no proof, no evidence, not only of efficacy, but more importantly, even safety.
Sure. They just don't know yet.
We don't know yet.
Yeah.
It might be the best thing since sliced bread, but we just don't know at
Right.
this juncture. And to a certain extent, we have to be safe. So the FDA says no to that. It's actually started shutting down a bunch of clinics.
Right, because I've had a number of patients who have come in saying that they've had stem cells through that method.
Yeah.
You know, so I mean, it's clearly happening even, you know, kind of in our area, and
Yeah.
so like that's a really good, you know, good information, because people are always wondering like, well, you know, could I just get like my liposuction and then stem cells simultaneously, because that sounds fabulous and we live in LA. But clearly, like, if this isn't a safe thing, then we need to be maybe not doing that or rethinking it, or at least until we know more.
Until we know more.
Yeah.
And the truth is, and this is, look, I'm going to go on a lot of tangents here, right? So just reel me back in if you need. But that's also why we're developing this field of what's called interventional orthopedics, because stem cells aren't magic.
No.
Right? So that being said, we want to be able to do specific things with those stem cells, or any orthobiologic. We want to be able to target specific structures that are necessary to be targeted. So if somebody comes to me like a Tammy with her foot pain, is it appropriate to just shove stem cells IV and just say that because they're magic, they're going to reach her plantar fascia and reach her back and treat all these things? Or do we need precise image guidance to see that we're going at these exact structures?
Sure.
Right? So there's a lot of folks that have clinics where they do liposuction. Their primary specialty is plastic surgery.
Yeah.
And they're like, hey, I'm also going to treat your spine condition.
Yeah.
Right? It's outside of their scope of medicine, and quite frankly, it's inappropriate. So
Doesn't mean it doesn't happen, but
right.
yeah.
Oh, it's happening, and it's happening all over the place.
Yeah.
And that's the thing. You know, anybody can call themselves a stem cell expert at this juncture, because there's no real
Certification
or anything along those lines. But the truth is that's just not appropriate as a pan-issue. It's not appropriate to treat everybody that has everything when you have a very focused specialty. Right?
Yeah.
So, you know, going back to my background, right?
Yeah.
I'm focused on the musculoskeletal system.
The orthopedic part.
The orthopedic part, right? So my training is in non-surgical orthopedics, and in doing these precise injections to these specific areas.
Sure.
Right? I've had further training in interventional orthopedics. You know, I've been practicing this for 4.5 years of purely doing this.
Yeah, just this.
Right. I'm not on the side treating somebody's acne and their dementia, right?
No.
So, or doing liposuction for cosmetic reasons. So, you know, For patients out there, if you go to a website and they say that they'll be able to cure 100% of all diseases, or they're treating multiple different things, you got to ask the right questions. Right?
Maybe you run the other way.
Or at the very least, delve into it further and figure out why, right?
Yeah. Ask more questions, which people are bad at because they just assume that you're a doctor, so you know what you're talking about. And so often, people just don't ask appropriate questions because they think that whatever the doctor's telling them is kind of the word of God, and people need to be better advocates for themselves.
That's absolutely right. And it's a weird world that we live in. Again, another aside. It's a weird world that we live in because on one hand, there's a lot of skepticism for docs that are in the traditional world.
Sure.
Right? Because those are the docs that are slinging opioids. Those are the docs that are doing unnecessary surgeries. But then, on the world that is still fairly experimental, for some reason, patients trust those docs and are like, all right, I'm going to give you $10,000 to put things God knows where, right?
Yeah.
So it's this weird dichotomy. It's this weird unbalance that's occurred in the musculoskeletal world right now.
Oh, and that's absolutely. It's like the things you hear and what people are, like you said, aren't trusting. I mean, there's no real sense to it, but maybe it's driven by media or things like that.
Absolutely. I mean, that's why I'm glad that you're doing this, and thank you for bringing me on because it's great to educate people about what's real and what's not.
Oh. Well, speaking of patients, let's loop back to Tammy because we got
way off
on our tangents. So let's talk about the second round. So the second round, we've got the amniotic. What did you call it? Not amniotic fluid.
So it's an allograft, meaning that it's a graft tissue essentially, even though it is a fluid. That comes from an allergenic source or a donor.
Sure.
And ultimately, what it is growth factors. So what I did was under ultrasound guidance, I could see the plantar fascia. The plantar fascia is layers of tissue essentially. And even though the MRI showed that the tear had healed completely, I could see that there was little slivers of stuff that were going on in there. So putting my needle through those fibers, I put the amniotic tissue to kind of coat the inside of what tears were remaining. And then I put bone marrow stem cells throughout that region.
Sure.
I also treated the other ligaments and tendons that were involved as a part of
on the ankle and just working on restabilizing and things.
Exactly.
Now, do you remember, did you do the spine the second time, or did we leave that alone?
I think we left that alone.
Yeah, because that was doing better.
It was doing better.
Yeah.
And functionally, on physical examination, her strength had improved. She was, for all intents and purposes, moving the way that she should be above the ankle.
Yeah.
So we really just needed to work on the ankle at that point. And then, of course, I had her, doing the rehab that was necessary. And that's really the work that you did with working with her is what got her going.
And it wasn't just me. So, I mean, this was kind of a team approach. So there's you and I involved. You're obviously doing the injectable treatments. She and I were doing restabilization, soft tissue manipulation, gait training, all these things. But then there's an acupuncturist involved who is helping with improving circulation, pain management, and a chiropractor involved too, helping, with just spine alignment, pelvic alignment, kind of helping to keep everything there happy. Because she was in a boot, on crutches. There are a lot of things, right, that were kind of contributing to her overall discomfort for a while as she was in this recovery phase.
Sure.
So we had lots of different people kind of with their hands on this process.
And that's the important thing, right? Having the proper team is really important in these situations. Unfortunately, a lot of folks that do these type of regenerative treatments will be like, hey, here's the treatment, and go. And truthfully, the treatment is only a piece of the puzzle, right? The prehabilitation, the exercise leading up to getting the biomechanics as good as possible, and the rehabilitation, perhaps more so, continuing on with that process is what's necessary.
And having everyone be communicating. I mean, this team approach only works if everyone's on board, everyone's communicating, working towards a common goal. And if everyone's kind of off doing their own things, it does not work well.
Doesn't make sense.
No, doesn't make sense for anyone.
And especially with these biologics, in this circumstance, with more of an acute injury that we're actually trying to heal the plantar fascia, or at least get it as functional as possible. If we just put stem cells there, it might not do anything. but we need that tissue to move the
Yeah.
way that it should be moving. That feedback is actually how healing takes place in an appropriate way.
Sure. We've got that feedback loop between the nerves and the brain, the tissues, and the tissues have to, like you were talking about how like they're kind of disorganized. Like we have to get them to lay back down in a more organized fashion.
That's right.
So that we've got the extensibility, elasticity that comes back into the tissues.
That's right.
Making sure that people are moving in effective movement patterns, because if they're moving dysfunctionally, that disorganization is just going to come right back.
That's
now
absolutely
we've lost the whole thing. You know, so that these things are really important. And also, I've talked about like we're kind of doing this combination of pro-inflammatory, anti-inflammatory treatment, but we're trying to get that proliferation, right? So you've got somebody who isn't moving well, so having a rehab specialist coming in and helping them to move and get blood flow and circulation on that area, like that's all highly necessary, because otherwise the treatment is not going to be nearly as complete as it could have been.
Yeah. The line that I use with all my patients is that I could put stem cells till the cows come home, but if you're not moving correctly, it's completely worthless.
Absolutely.
Yeah.
So, talking about Tammy, like where she's at now, now she's back in her shoes. She's talking. She's talking. That was not exactly what I meant to say at all.
Talking before.
We really fixed that. Not what I meant to say. She's. What I meant to say is that her psyche is improved. She's coming in, and when I'm talking with her, the first thing that out of her mouth isn't my foot. Which is so important, is that she's back doing the things she loves. She's back exercising again, which is really important for obviously overall well-being. But it was one of her main goals. She's working her big crazy days, doing all the kids stuff. So now we're in a phase where she's meeting these goals, and we avoided all the opioids, we avoided the cortisones, we avoided the surgeries, and we've had really a successful case with her.
Yeah, she's been one of our all-stars by all means.
Yeah.
She's really done fantastically. But an important thing to realize, though, is that even though we were able to get such great success out of this, does she have a 12-year-old's foot again?
No.
Absolutely not.
It's not like we gave her a new foot.
We haven't regrown her spine. We haven't regrown her foot. We've stabilized things.
Yes.
We've improved the function of these tissues. We've healed some tissues to a certain extent.
Yeah.
But we can't reverse the clock. Reverse the hands of the clock.
Yeah. There you go.
But the truth is, we can get patients functional with decreased pain and living their lives.
Yes.
Right? So I think that's where this teamwork approach is really fantastic.
That's awesome. So we've all been talking about the plantar fascia. So we've had a lot of other patients. We won't talk so extensively, but let's talk about just maybe some of the other kind of common conditions that you would find would be appropriate for these type of treatments. Like, who are people that when you see them in clinic, you're like, yep, this is something that we can generally help? Because obviously, again, this isn't like we're trying to treat everything. Right. So what are some of the common conditions that you would suggest might be a good candidate to at least come in for a consultation?
Sure. So I'll talk about the things that I think we can help, but first let me talk about the things that I can't help.
Sure.
Because I think that's equally, if not more important, right?
Yeah,
because,
absolutely.
If anyone's listening to this and saying, hey, I have X condition, is it worth it to come in to see me, right?
Yeah.
So first and foremost, the things that I can't help.
Sure.
When we have patients that have had multi-traumas or fractures that are displaced and major orthopedic traumas, those need orthopedic surgery.
Yes, or complete ruptures. Like a muscle tendon that's ruptured and retracted. Absolutely. We're not going to be able to pull that thing back with this type of treatment.
Absolutely. So an example of that is the ACL in the knee.
Sure.
We hear of the ACL being torn in football players, basketball players, and
every day.
Every people, right? Soccer players and young girls playing soccer and landing funny, tearing it, right? That's all the time.
All day.
And we hear a lot about ACL repair surgery, especially it's common in the media with our professional athletes, right? But we've actually realized at this juncture that for partial thickness ACL tears and even some full thickness ACL tears, we may actually be able to heal the ligament using a patient's own bone marrow stem cells and blood growth factors.
Sure.
And the folks that have trained me, the folks that I work with, have developed a way of actually injecting both bundles of the ACL under X-ray guidance and getting that precise injection in order to actually heal it. And we've had a lot of patients that have had some tremendous success with it.
Yeah.
That said, you mentioned when the tear is so bad that it's retracted, you know, if this is the ligament here and the tear is like this, that's one thing.
Yeah.
But if the tear is like this and we're flapping in the wind, there's nothing we can do to bring that together.
Yeah, it has to be approximated in some way.
Exactly.
You know, and this might be something that you could do after a surgery.
Potentially.
Or maybe even in a surgery.
Potentially.
But it's not going to fix that full retraction.
That's exactly right.
The same thing with rotator cuff tears. I mean, that's something we both see. You know, it's like you've got a retracted supraspinatus tendon, like, or whatever. I mean, that's we can't get that pulled back down.
That's exactly right. You know, if the fibers are completely dissociated, then that needs surgery. Now, correction, that could need surgery.
Could need surgery. A lot of times people don't have surgery because functionally they're okay.
Perfectly fine.
And the pain isn't unmanageable.
And that's what a lot of people don't realize, right?
Yeah.
Because a rotator cuff tear does not necessarily equal pain or dysfunction.
No.
Same thing with an ACL tear.
Absolutely.
Right? Especially when patients are getting a little bit older and they have an ACL tear. Does that mean that they need to get it repaired? Not necessarily.
Depends on what their goals are, right?
What their goals are and what their function is, right? Because if you have a rotator cuff tear, but you're able to do this,
Yeah.
all right.
Or this.
Right, or that.
There's
right?
the wing.
then you may not need surgery, right?
Right.
Or if you have an ACL tear, but you feel stable, then you may not need surgery. We have to be realistic with what's going to happen 10 years from now, right? You're going to develop arthritis in that knee or that shoulder. But that would happen even if you had the surgery.
Right. Because you still had a trauma.
That's exactly right.
Yeah.
And with something like an ACL surgery, the fibers, you're never going to have the same proprioception that you had with your original ACL.
Sure.
So there's always going to be some level of arthritis that increases in that, and that's been shown in the literature as well. But if you need that knee for functioning, if you're unstable with that ACL, if you are a professional athlete or have aspirations to be very, very active and you're feeling that instability, then that is a reason that surgery may be necessary.
Yeah.
But you know, I had a dancer, a ballet dancer, ballerina, who is 65 years old and still dancing, and she had an ACL tear repair several years ago, and her knees never felt the same.
Sure. And that happens a lot.
And that happens a lot, and especially with someone like a ballerina who's very, very attuned to her body.
Yes.
Even subtle things, for all intents and purposes, her knee is stable, but those subtle things she was feeling, she wasn't able to turn the way that she wanted to.
Sure.
And dance the way that she wanted to. In any case, it's one of those things that those are the situations that even if you do have a major ACL tear, but you're feeling stable and you want to try to avoid surgery, we may be able to use biologics to strengthen all the other ligaments in the area, change the negative environment inside the joint, try to prevent things from getting worse, or at least slow down the progress of the arthritis. Not necessarily grow back the ACL in that situation, but still potentially help.
But kind of give that kind of global stability that's needed.
That's exactly
just
right.
in a different way.
That's exactly right. And the same thing goes with rotator cuff tears. If there is less of a retraction, if there is a small tear in the rotator cuff, we may actually be able to provide benefit. And we've had some cases of actually healing those rotator cuff tears.
Well, I can use mine as an example. I mean, you've done my shoulder twice now, but 2 years apart. And it wasn't like you just injected into the joint itself. We were doing multiple tendons, then we were doing the actual labrum itself and doing things to stabilize globally as well as the tear site. And that was super successful without having to do the surgeries and whatnot. But, dumb and did another injury. So, had that not happened.
Not dumb and did another injury, but living the life.
Yeah, I should have asked for help lifting that box, but usually fine. So, but I mean, the important thing to know is that the function is there, the pain is manageable, and we were doing something more global. We weren't just trying to fix a tear site, and working on that general stability, and obviously working on rehabbing myself and building strength and all that stuff on top of it.
Absolutely.
But yeah, I mean, that can be highly successful.
And that's the great thing is we can provide benefit in terms of pain and function, even strength of certain tissues, without resorting to things like cortisone injections,
Sure.
which may actually make tendon issues worse.
Yeah, weaken it.
Especially if they're unguided injections, which a lot of folks are doing. Don't use any image guidance to kind of inject into the shoulder. And theoretically, anybody can kind of inject into the shoulder, right?
It's a big thing.
But if it gets into the tendon, it can cause a tear.
Right.
I've seen patients that had biceps tendon inflammation, and they had injections of cortisone without any image guidance to where the biceps tendon is, and they went from just having inflammation to a full-on rupture there.
Yeah, and this is like, oh my God, the soapbox that I get on with patients about this, because for me as a therapist, I'm the one having to deal with them for months on end. I'm not saying it's a bad thing, but I'm just saying we have a multi-month relationship. They go to see their orthopedic surgeon, they have even a small tear, or like you said, a tendonitis, tendinosis, they get cortisone, and we go from a minor condition to full rupture, and now we're looking at surgery. So it's as much as I can, I'm trying to guide patients away from having the cortisone, because where it has its place when we're talking about these tendinous tissues and these structural support tissues, it just really isn't doing them any favors. And we used to do it more because we didn't have other solutions. And now we have other solutions which might be better solutions, so why not go to that route?
Absolutely.
Oh.
And don't get me wrong, I think cortisone has its place.
It does, for sure.
But quite frankly, as time progresses and research progresses, that window of what we should be using cortisone for is
smaller and smaller.
Smaller and smaller.
Absolutely.
So, for the back and sciatica, for example, if somebody is young, has no other medical issues, has an isolated disc bulge that's irritating a nerve, then okay,
might be
maybe
appropriate.
an epidural steroid injection is appropriate.
Yeah.
That's not typically the patients that we see, though. Right?
No, and we do have them occasionally, but that falls in our small window of something that, yes, give that a shot,
But if it only works for 2 or 3 months, certainly shouldn't be repeating that over and over again.
No, because obviously we're not treating the underlying problems like we talked about, and there's other things that need to be addressed, not just bandaged.
That's exactly right. And a lot of times when situations like that, people go to their doc, they get that injection, and they don't talk about rehab afterwards.
No, they don't.
Because they had the cortisone works to calm down the inflammation, so they feel less pain, but they don't think about what caused the issue in the first place.
Right. And the therapy or rehab or whatever isn't being pushed because the patient's not in pain. And so many people, if they could come in preventatively, we could literally do prehab with them versus chasing the pain and chasing the dysfunction when someone's in a lot of discomfort. I mean, it'd be so much easier to hit it on the front end.
Absolutely.
Those are my favorite patients to see, is I've got this little problem, but I want to make sure this doesn't come back. Awesome. I want that. And people always joke with me, they're like, isn't that bad business? Bad business for you? You're preventing this person from needing 4 months of surgery? I'm like, absolutely not, because if I prevent you from needing surgery or having more cortisone, you're going to send all your family and friends, because now you really like me because this, it didn't turn into a bigger problem. And I love those cases.
And I think that's the main thing, right? Because you're helping people.
Yeah.
And you're being honest with people, and you're preventing more invasive things. Right. That's the thing, you might stop them from coming to see you more, right?
But
so it's bad business, but it's good patient care.
Absolutely.
And the worst thing, I was actually just on a physician group on Facebook, and somebody was talking about how they had sent a patient somewhere for cortisone injections in both shoulders and a knee. And they had a ridiculous, but they had a ridiculous high amount of cortisone that was injected in all those 3 areas, and they were asking, is this normal to have this amount of cortisone injected?
Yeah.
And people were like, no, this is not normal. Maybe it's an error on their documentation or whatever it may be. But I was like, look, there are actually groups out there, and I'm not kidding here. There are groups out there that are like, all right, let's throw whatever we can at them.
Yeah.
I don't really care if it works or not, because the next lineup is going to be the surgery.
Right, and it's kind of you almost feel like they're trying to push people in that direction a little bit, because it isn't good patient care, because they're not looking out for the patient. They're just kind of patching it and going well, if this doesn't work, I'll cut you, which is really unfortunate.
And what's worse yet is that with those high levels of cortisone injections, we now know that cortisone actually makes arthritis worse.
Yeah.
Especially repeated injections, especially high levels, right? So it's a great business model.
Yeah.
You know, let's do a bunch of really, really high cortisone injections that may reduce the pain temporarily,
Yeah.
but then they keep on coming back because it's temporary, and it makes the arthritis worse, so then you end up having to have surgery.
Sure. It's just
right?
bad patient care all around.
It is immoral. And there was, years ago, I was looking at jobs, and a buddy of mine told me about a job in Texas.
Okay.
And in looking into it further, they were doing epidural steroid injections for the low back,
Okay.
but they didn't want their physicians to use the x-ray in multiple views and make sure that the needle was in the right place.
That's
they were
just
just
dangerous.
like, just go in and go out. It doesn't matter if you're in the right place, because they were a surgical team. And they had money in.
This just makes me cringe.
And this isn't the norm.
No, but still.
Most people aren't like this, but they had money in their ambulatory surgical center. They had money in their surgical equipment company, and all of that. So that was where they were bringing money in. So they had somebody in doing conservative care, but ultimately it was just pushing people towards surgery.
Yeah.
Rumor is that Texas is notorious for this type of care. I've heard of several clinics like this. Not everybody is like this.
No.
I know and am personally colleagues and friends with good surgeons.
Yeah.
And quite frankly, I do think surgery is absolutely necessary in many, many situations, but the system has become crap. You know? But yeah, talk about a tangent there.
Yeah, I mean, we can go on that for a while. So we talked about, we've talked about a little bit of ACLs. We talked about rotator cuff tears a little bit.
Yeah.
What would be other appropriate things, for people to come in for, like, just, ballpark, just a few things that are common, and then I have a specific question.
Sure.
So,
So for things like PRP, the platelet-rich plasma, the most research is actually for things like tennis elbow.
okay.
Things like mild to moderate knee osteoarthritis.
Okay.
And if I was to wager a guess as to what's going to be covered by insurance for PRP in the
When
near
that ever
future,
happens, yeah.
I think those would be the areas that would probably be first. Perhaps tendinopathy or irritation on the outside of the hip at what's called greater trochanter.
Sure.
So these are the areas that there's most research at this juncture.
Okay.
The problem is the research is all over the place, because PRP is not just PRP.
Yeah.
There's multiple different ways of making PRP, and we've realized that different types of PRP are beneficial for different conditions.
Sure. Like we were talking about before, where the cells are coming from, or
Correct.
et cetera.
Correct. So the different biologics are necessary for different conditions, and we're still figuring that out. But we are really able to make those various different things, and that's why we are specializing in this versus somebody that might just be doing this on the side, right?
Yes, and that's part of what's so great, is that this is what you guys do.
Absolutely.
It's not like you're going to see somebody else, that this is like a side cash, it's kind of a side hustle, and that sounds bad, but that this isn't their primary thing.
Right.
For you guys, this is the primary thing. So you guys are doing the research, you have the numbers here.
We're collecting the data.
And
making sure we know what we can and cannot treat. So, looking at our data, we do have benefit with PRP for milder arthritis conditions, for tendinopathy or irritation to the tendons, like disorganized fibers of the tendons. We do have benefit for more minor spine conditions.
Yeah.
So arthritis to the facet joints.
Right.
We use a variation of PRP called platelet lysate, which is more of a soothing anti-inflammatory immediate release of growth factors versus PRP, which actually causes inflammation first. And that platelet lysate I can use in the epidural space instead of an epidural steroid injection.
Right, kind of could take the place of that cortisone we were talking about earlier.
Absolutely, and more so than just taking the place of it, because it has that anti-inflammatory effect.
And the growth factors. Yeah, that's an important distinction.
Yeah, so we've had patients that had nerve damage actually have improvement of their nerve function with using that platelet lysate into the epidural space or into peripheral nerves or whatnot.
Right.
And we can even treat muscle conditions with PRP and platelet derivatives.
Okay.
So, for example, I had a case of a patient who had nerve damage after a accident.
Okay.
And he actually had surgery, had improvement, ended up having to have a second surgery, after which he had significant atrophy of his muscles.
All that weakness.
All that weakness. He literally couldn't lift his arm. He had 0 out of 5 strength. I saw him several months later, and his surgeon was like, hey, we just got to wait 2 years and see what grows back.
Right.
But nothing was growing. So we were like, look, we can try to do this. This is still very experimental, but we have had success at getting nerves to function better.
With that introduction of the growth hormones.
Exactly, with the growth factors.
Growth factors, not growth hormones.
But so we injected along the nerves in the neck, and he started to get some tingling.
Okay.
So we started injecting also into the various muscles
Fascinating.
as well.
Okay.
After a few injections of injecting the nerves, we continued to inject into the muscles, and he actually had regrowth of muscle and improvement of his strength.
That's
very
great.
Substantial improvement.
Yeah, because coming from a 0 out of 5, which is like, if people don't know this, like 0 out of 5 means you can't move. I mean, we're talking flaccid muscle. Like there is nothing there.
That's right.
So for coming back from that, I mean, that's pretty remarkable.
Yeah. And he didn't get to 5 out of 5. He didn't get to complete strength.
Yeah.
Actually, in some areas he got close, but he was like 4 out of 5, 4 plus out of 5. He was 3 out of 5 at some muscles, but he had some substantial improvement.
Sure.
It was actually really emotional for me and my staff. Like he came in giving high fives.
Oh, that's huge.
And throwing punches.
Yeah.
And he returned to swimming, which he loved. Like it was just it was a great story.
That's really cool.
And yeah, it was really cool. But see, that's a situation where it's a little bit more of an acute injury,
Right.
where we actually did regeneration. But a lot of these conditions like arthritis, we're not actually regenerating the joint.
Right. You're not growing more cartilage.
Correct.
Which people think that's what's happening. They think, oh, they're going to inject this, and I'm growing the cartilage back.
Correct.
Not exactly.
Exactly. And
Yeah.
and that's the thing, because going back to all these scam clinics that are out there, there's people that are making those claims.
Right.
And they're trying to show actually before and after X-rays even. I got to show you this. One of my partners.
This can be one of our things that we like have like on a demo, right?
Yeah. When one of my partners sent me a picture of a patient's ankles.
Okay.
Her X-rays of her ankles, and that she had taken before and after at this clinic that she visited that did some umbilical stem cell treatment,
Okay.
and said that they were going to regrow her cartilage.
Okay.
She had no improvement. Surprise. She had really bad arthritis. But they did the repeat X-ray,
Yeah.
and they measured the joint space to show that the cartilage had grown.
Okay.
Just so the audience knows, X-ray
Yeah.
does not show cartilage.
Right.
It shows joint space, but it does not show cartilage.
Doesn't show any sort of soft tissue.
Correct.
Yeah.
And they measured it and said, look, the measurement has grown. The size of the joint space has grown.
The size of the joint space is growing?
Yeah.
Okay.
But they actually measured it at a completely different location.
Oh.
At a completely different location. Just moved the marker down a little bit and measured at a different location.
Sure.
And showed the patient, hey, look, see?
Yeah.
The measurements
And how would the
have improved.
patient know?
The
This isn't.
patient doesn't know.
The patient doesn't know. So to them, this probably looked awesome.
Yep.
Like,
You know, like even though my pain is still the same as it was before, at least I'm regrowing my cartilage, right?
Yeah.
So it was really sad. We see this all the time. I see patients with before and after X-rays of the knees, but they show the knees and they show a joint space like this that's completely narrowed, and then they show the next one that's actually increased, but the angle of the X-ray is completely
Different.
off. So you got to look at where the kneecap is in the picture, right?
Right,
because if
right.
the kneecap is in a different location, then the X-ray is taken at a different angle.
Yeah,
right?
it's like comparing apples to oranges now. Like, it's not the same
It's
thing.
not the same.
Yeah.
So in those settings, in more chronic degenerative conditions, we may still be able to improve pain, improve function with targeted injections into various ligament structures. We may be able to improve the strength around the knee joint or the whatever joint, but we can't regrow the cartilage.
Yeah.
We can't reverse the arthritis that has taken place.
Again, we're not putting the clock back.
Exactly.
Oh.
Exactly.
So specific kind of question. So, in my clinic space, we do a lot of orthopedics. We're also doing pelvic health. And to be specific, we're doing pelvic health as a generalization. Not just women's pelvic health, but also men and the whole spectrum. Everyone, doesn't matter your gender, has a pelvic floor. I think we can agree on that.
Yeah.
But people get confused. Like, a lot of times men don't realize that they have a pelvic floor also. But with women, one of the questions I get often is we get a postpartum or after childbirth clientele base. And one of the biggest questions I get is, what can I do about my diastasis recti? And I wanted to talk to you about this specifically because this is a question that's over and over asked, because women are very concerned about getting their waistline back,
Yeah.
being able to get their abdominal strength back, both for function and aesthetics. And it's a big concern for them. So, in that population, is there something that you guys do here that could help with helping that diastasis to close or become more thickened, things to kind of help to rebuild that for this population?
Yeah, I think that's actually an emerging area that I think we may be able to help. So, interesting story about that actually. Several years ago, 3.5 years ago, I was actually treating some guys with low back issues.
Sure.
And I had some improvement of their nerve function, but I wasn't able to get them to strengthen their core to take pressure off of the area. So on follow-up, even though they had improvement of most of their symptoms, I wanted to make sure we had some longevity, so I was really focusing on getting them core strength. And I realized that there was something wrong.
Okay.
So they had that diastasis.
Sure. And in the men, we usually talk about like some sort of like an abdominal hernia, right? Versus using that same term.
Yeah, but the truth is that's what it is. It is
Same
a
thing.
diastasis, right?
Is that thinning of the linea alba, and it's the ab muscles are separating another space.
That's exactly right, and it happens quite frequently in both men and females, and it can be something that's there since birth, and it just could be the way that you are. But in this particular population, it was some men that had gained and lost weight.
Okay.
So if you think about what pregnancy is, right?
Yeah.
Ultimately, that is stretching of the abdomen, stretching of the linea alba between the recti, and then coming back. But that linea alba ends up being stretched. It ends up being fragile.
Thin. Yeah.
Even wavy in appearance because it has been stretched. And now, if you think of it like a thick rubber band, and then you slowly stretch that rubber band, but then you put it back into position, what's going to happen? It's going to be kind of
it doesn't have that same integrity that it did the first time.
That same elasticity, that same strength, right?
Yeah.
Tensile strength. So ultimately, I was like, all right, I have this patient population. Then I started seeing it more. I started examining it more and seeing it more. And this is something that we don't learn about in depth in medical school or in residency training or whatnot. But I remember that in my residency when I was all on the East Coast, I remember seeing someone that in New York City that had developed an abdominal strengthening program for diastasis that focused really specifically on strengthening the transverse abdominal muscles.
Okay.
So I actually reached out to her and I was like, hey, look, what's your experience with this? Can you help me out with this? And we started talking, and she had mentioned that she had a lot of refractory cases.
Okay.
She was collecting her data, so she knew what patients did well and what didn't. And she had cases that they did the exercise, but they still weren't able to close that gap of the diastasis. In my residency program and beforehand, I had actually met one of the pioneers of some regenerative medicine techniques down in Washington, D.C., a guy by the name of Dr. Victor Ibrahim.
Okay.
And while I was following him, he was actually going to be working on a potential study to look at micronized fat from the abdomen. So not stem cells, but just micronized fat, and injecting that along the linea alba in order to try to provide some healing along there.
Okay.
So I reached out to him and I was like, hey, what do you think about just trying to inject PRP?
Yeah.
He loved the idea. So I worked with this lady from New York on a few different patients. We did her exercises for a few weeks, and then with ultrasound guidance, I injected along the linea alba, and then they continued on with their exercises. We followed these patients out to a couple months, and then even several months later, and did before and after pictures. We did before and after measurements by hand. We did before and after measurements under ultrasound, so seeing the width of the linea alba as well as the thickness of the connective tissue. And we were very pleasantly surprised to see some pretty substantial benefit in all of our cases. Now, we only did a limited number of cases, and this wasn't a formal study. There wasn't no control that we did or anything along those lines. But some of these patients were patients that had done her program previously and still had a diastasis.
Fascinating.
So it was really, really interesting. And since then, I have worked with other physical therapists that work with patients in strengthening the transverse abdominal muscles and doing that in concert with PRP along the linea alba.
Yeah.
Unfortunately, Dr. Victor Ibrahim passed away. It was actually a really big loss to our community. So I don't think that the studies that he was doing came to fruition.
Okay.
But we were working on publishing the cases that we did. And quite frankly, I think that this is something that could really be beneficial for a lot of patients that are honestly neglected.
Yeah, absolutely. I mean, it's a population that, like you said, you didn't get a lot of formal training in this. The number of patients I have that come in to see me that their physician has never mentioned to them that this is a thing.
Never heard of it.
They've never heard of it.
Yeah.
And it's like, these are highly trained individuals, but this just isn't part of the training.
Right.
It's pretty unbelievable. So you might have somebody who's been struggling with this for several years before they land in someone's office that actually recognizes and knows what this is, and now can do something about it. But it's really cool finding other potential treatments for this, because it's a major concern for a lot of people. And especially like you get the population of people who are really active, and they aren't able to get back to their activities because they don't have this stability in the front.
Absolutely.
And also, two things that we know now about the use of mesh for closing hernias and these things, like, the FDA has retracted on the mesh and said that this isn't safe. We, know that foreign body being implanted isn't great. So having a potential option is really a great thing to kind of be hopeful for.
Yeah. And in certain situations like that, the surgery may be necessary. If there's a
Absolutely.
rip in the linea alba, and if there's a true hernia,
too wide,
right?
yeah.
Then those are the circumstances where surgery may actually be necessary. But if we can avoid it,
Absolutely.
that's really, really important. The reason that I think that this has been neglected for so long is, quite frankly, you fall into two categories. That category where there's a true hernia, where abdominal organs are coming out, and that's a surgical candidate. Or you fall into the category that has this diastasis, but doesn't have any broad symptoms that are presenting, right? It's not necessarily a painful thing. It causes weakness, but ultimately that weakness demonstrates as difficulty with activity, or back pain, or whatever else, but nobody's paying attention to the kink in the armor, so to speak, right? So I think that's why it's been neglected so long, but that's why people are starting to pay attention to it a little bit more too.
And and a lot of people, it's like, because it's an aesthetics issue, right? They're seeing maybe a plastic surgeon about it versus seeing like their OBGYN or a functional medicine provider, because they're looking at like, how do I make this look better, but not really necessarily thinking about how that can make them function better.
Right. And I mentioned before that I don't like the idea of plastic surgeons doing orthopedic conditions.
Right.
I don't consider myself an aesthetic person at all, so I'm not doing this for aesthetic reasons.
Yeah.
Although I have had patients come to me because they do have some difficulty with their core strength and would love to feel aesthetically better.
Right.
Ultimately, I'm not going to be trying to make this look pretty, although I've had that success with the patients.
Yeah, but the goal isn't that.
Yeah,
the goal is the functional part.
And that's how I fell into it, because I wanted to use this as an adjunct to the treatment that I had for a guy with back pain, right?
Yeah.
But it ended up being very, very successful, and I've treated since a bunch of female that are postpartum that have this residual diastasis going on.
And in terms of like the pelvic health world, I mean, this is an important thing to talk about, the fact that, yes, we're talking about diastasis, but a male coming in with a hernia, they're going to have this same core weakness, problems, low back pain, difficulty functioning. So this is a potential treatment for both groups.
Absolutely.
Same problem, just called something different.
Absolutely. And we're still learning a lot about it. We're still learning, where it won't and will work. But I've had more success than not. And we're looking at the details of what length may be too long, or what kind of diastasis would react better to it or not.
Sure.
But it's certainly something to try before surgery.
Yeah.
And certainly needs to be done with the appropriate rehab.
Right. The rehab, and also like we were talking about, like making sure it's the right type of cells going into it. You're using ultrasound guidance, things so that you know that you're getting it where it needs, getting the treatment where it needs to be, and then partnering that with the rehabilitation.
Absolutely.
Oh, cool. Hey, I know we could talk about that, like literally keep talking for the next day, but we should probably wrap it up. Oh, thank you so much for meeting up with me. I absolutely appreciate it. I appreciate you and what you do, and the help you've given to me and my patient population. So thank you so much.
No, thank you. Honestly, thank you for having me. This has been a lot of fun.
It's always fun.
Yeah, and I thank you for the opportunity to just let me explain what's real and what's not.
Yeah,
You know,
so
obviously
important.
We're only hit the tip of the iceberg. So.
Literally scratch the surface. But it's good information for everyone to have.
Well, thank you for having me.
Thank you. Appreciate it.